Okay, good afternoon everybody. Thank you for attending this 2 o'clock session entitled Interventions to Enhance Hepatitis C Testing and Treatment. We've got 7 fantastic presentations for you today. We've got a few 15-minute ones and then some rapid-fire 5-minute presentations after that. We will be having questions after each presentation, so if you wish to ask a question, please either approach one of the microphones on the left or the right of the auditorium, or you can do it on an app if you're so minded, and the questions come up on the app here for us to ask. I'd like to remind people that if you're joining us for the conference dinner, and if you're not, I want to know why, because it'll be fantastic. A reminder for you that this starts at 7 o'clock tonight at a place called Platform on Argyle Street, and that's in the Glasgow city centre, and your ticket to ride is your conference ID badge. Okay, so bring that with you or you will not be admitted under any circumstances. My name's Philip Reed. I'm a sexual health physician and director of the Kirkton Road Centre in Sydney, and my co-chair, I shall introduce, can introduce himself.
Yeah, hi, good afternoon. Thanks for joining us. I'm Stephen Barclay. I'm a hepatologist at Glasgow Royal Infirmary. A few train stops along the line, but not as far as you're going this evening, which I'm sure will be great. We have strict timekeeping. I've got a bell here, which if I ring, it means either the time is up or that we have to change Prime Minister, which is a quirk that we have in the United Kingdom at the moment. Without any further ado, I'd like to introduce the first speaker, which is Brendan Harney. Brendan's a PhD student at the Burnet in Melbourne, Australia, and he's going to give us his presentation on recruitment and treatment of social injecting networks in the treatment and prevention study, a real-world social network design community-based trial of DAAs for HCV amongst people who inject drugs. Thank you, Brendan.
Great, thanks a lot, and thanks to the organisers for allowing me to present this work this afternoon on behalf of the large team here, and particularly Dr. Rachel Sachs-Davis, who basically did all of the hard work to put this together. I'd like to acknowledge that this work was done on the stolen lands of the Boonwurrung and the Woiwurrung people of the Kulin Nation. I'd like to pay my respects to elders past, present and emerging. I'd also like to acknowledge that this work would obviously not be possible without the contributions of people who inject drugs, and I'd also particularly like to dedicate this presentation to those who were enrolled in this study who passed away during it. This study was funded by Gilead, but they played no role in basically any of what we did, apart from giving us money. So just a bit of history. Burnet Institute has been working working with people who inject drugs to help improve health outcomes for a number of years. And this work has really been driven by a lot of work we've done on social networks among people who inject drugs, and particularly looking at the molecular epidemiology, which showed that the social injecting networks are a very important part of how hepatitis C is transmitted. And going forward, Margaret Hallard led some modelling work to basically look at how we can use what we knew from this molecular epi stuff to inform treatment strategies, so using in particular what we call the treat your friend strategy. So the TAP study, treatment and prevention study, the co-primary aims are listed at the top there. You can kind of ignore that, so I'm not talking about that today. What I'm talking about is looking at individual and network level factors associated with recruitment of nominated network members as what we call secondary participants, and describing the good old cascade of care among the study participants. So we recruited people from a long-running super mixed cohort led by Burnet researchers. The primary participants needed to be Hep C RNA positive and report injecting with one or more other people in the previous 6 months. Any kind of substance use was not an exclusion, but I should say this did start even actually prior to DAAs being listed on our pharmaceutical benefit schemes. So yeah, there was a bit of complication. So people with cirrhosis, HIV, HPV and other various things were excluded from this particular study. Basically, what happened, these primary participants nominated people they'd injected with in the previous 6 months. It's what we call secondary participants. These people could be RNA positive or negative. And as part of this study, nurses did basically everything because they can. And yeah, they had discussions with the clinical investigators. Most of these people never saw an actual medical doctor. So yeah, the primary participants named the people they injected with in the past 6 months, introduced them to the study nurses, some not particularly great reimbursements for participation, but we also had what we call, well, later on recruitment, which I'll explain more shortly. So we were looking at factors associated with recruitment of nominated injecting partners using logistic regression. And I do need to clarify, this is very much a post hoc analysis. This was never actually part of the plan for this study. So we had 116 primary participants and they nominated 176 people that they injected with in the previous 6 months at screening, and 60 of these people were recruited to the study. And then we had 82 people that were recruited later on during the study, so that the primary participants had injected with these people during the study as opposed to prior to the study. So this table here just shows some of the differences between the people who were recruited and not recruited. So, I mean, you can see it yourself, but basically the people who were recruited more likely to be, spouse de facto relationships, other family members, whereas in the bottom there you can kind of see friends and acquaintances generally, well, particularly acquaintances or other, were generally not recruited but that well. So looking at the factors associated with recruitment based on the characteristics of the primary participant, as opposed to being Australian born, if the primary participant was a migrant, so from any other country than Australia, the people they nominated were considerably less likely to be recruited to the study. This table here is looking at the relationship characteristics. So you can see there, basically compared to people being very close, those who were less close were less likely to be recruited. But people, if they were injecting together in a private home, was a strong relationship there. Likewise, sex partners, and if they'd shared needles or syringes. And again, compared to always injecting together, people who didn't always inject together were less likely to be recruited. So this is looking at those, what we call the late secondary recruits, and the one that stands out there, and I just mentioned this to Evan, so we can actually see that the only thing that's standing out there is incarceration in the previous 12 months was associated with recruitment of the late secondaries compared to those nominated at screening, which we found quite interesting. So again, looking at those relationship differences between the late secondaries and those nominated at screening, we can see there that that 90% there compared to the 77%, and again, that frequency of injecting, comparing the two different groups. So everyone loves a good cascade of care. Obviously couldn't do a presentation without it, so pretty much standard things at the top. Just to point out, all the primaries had to be RNA negative, whereas the secondaries didn't necessarily have to be. That's why you get that difference there. But you do see a bit of a difference in the treatment initiation. Likewise, SVR testing, but as we know, if you have an SVR test and you've completed treatment, it's pretty much, decent cure rates given this kind of outreach population we're dealing with. So looking at the secondary participants based on nomination at screening. So as I've discussed, they were basically very close relationships. And this makes sense, right? Because, they're more stable, there's more trust, and they're probably a very key network for potential reinfection, which is obviously very important that people you're going to be injecting with are both treated at the same time to reduce that risk of reinfection. Late secondary recruits, were people not injected with prior to screening. They were probably maybe more distant relationships or not available at screening. And as I said, incarceration was a bit of a predictor of this. And it's quite interesting because the number of people recruited later in the study was actually higher than at the beginning. So we think this is, as we all know, this is a really indication that people are being like, hey, I've been treated, you go and get treated now too, and I'll tell you where to go. So obviously some limitations. This was a research study with reimbursement, so it is unclear to what extent these results will generalise to standard care, but as we all know and might hear about soon from Evan, incentives are becoming a little bit of a thing. So, this maybe is actually a limitation because it could be really interesting to see how incentives are used with this kind of style of treatment among networks. This was in, as I said, the very early days of DAA availability. So some of that non-recruitment of the people early on might have been because, they've been treated with interferon, which, as we all know, is shit. And later on it became more acceptable. Simultaneous treatment was a bit complicated because it was very hard to get people there all at the same time, but we loosened up that requirement. So sometimes people, the primary might get treated, then it might be a few more weeks until their secondary contact got treated. So in conclusion, network-based recruitment is quite complex and very context dependent. As I just said, challenging to implement simultaneous treatment. But there is definitely overlaps, I think, with concepts from peer models of care, which we're obviously talking about a lot at this conference and have been for a number of years now. And yeah, as I said, people are seemingly very willing to be treated. Once they're treated, willing to recommend it to friends. And this is just a quote here for any of the qualitative researchers in the room. I don't know if Lise is around, but anyway, it's just a quote from one of the participants that we did some work with later. Just really remembering that all these people, there's a lot of issues going on in their life and we need to tailor the models of care to their circumstances. So as April points out, she didn't have to go to a chemist even, she just went to the fan, spoke to the nurses, Kate and Sally, those who know them, they're legends. And yeah, as she says there, knowing someone was keeping an eye on it and gave a shit whether I was healthy or not was, a really strong motivator for her to get treated. So yeah, that's it. Thank you very much. There's just some acknowledgements there. And if you have any hard questions, as I said, Rachel led the analysis, but I'm happy to answer any easier questions or hard ones.
Excellent, thank you, Brendan. So up to the microphones, over there. Is that Jason?
Jason Grebley from the Kirby Institute. Great job, Brendan. It's nice to see the results from the study now being published. I think it's an easy question, and I think you may have covered it, but just want to make sure I get the interpretation right. So would it be safe to say that the primary participants, perhaps the sort of cascade outcomes were a touch higher because they were a population that was more engaged in care and they came forward, and the secondaries maybe are on a different stage of the contemplative sort of scale of treatment, and so that's the only reason why they didn't engage as much. But the SCR was reasonably similar across both, so which is fantastic. So that's my first question. If you think that kind of makes sense, that interpretation.
Can I answer that before you ask
Sure.
another one?
Yeah,
so,
sure.
Yes.
Okay,
yes,
great.
the simple answer. So yeah, as I said, so these people, the primaries were, the vast majority were recruited from Supermix, which is our cohort led by Paul Dietz. And some of these people have been involved in that cohort for, literally 10 years. Not all of them that long, but yeah, so they are, and it's an ongoing longitudinal cohort. So yes, they are more engaged and they know the field workers. So that would be part of it. Yeah.
And anything from the qualitative research that suggests what people in the secondary networks, what might have helped get them across the line? Is it incentives, increased peer support? I guess there's a whole host of things you could, but just, any insights on that?
So not a lot. So Steliana Gutsamatsis, I think it's the pronunciation. So she did some, she basically did all the qual stuff for this. They actually struggled to recruit the secondary people post-doc. They probably should have maybe thought about speaking to them quite early on.
Sure.
So there's nothing really we know, but yeah, like I said, we had reimbursements for study participation, but they were, not great. So I would suggest now that we are thinking more incentives and actual like proper incentives would be a really good way to think about it. Yeah.
Great job.
Thank you, Jason.
Yeah, go on. I think we've got time for a quick question and reply.
Okay.
Yeah, thank you so much. This is fantastic. I'm Andy Seaman, Central City Concern in Portland, Oregon. We have a very, very similar incentive program, probably done about 1,000 or so folks in this model. Same, even $10, same fees for referrals. And I think one of the things we're struggling with is that we, the incentives work. They do get some people to get tested, but they don't seem to be prioritizing the injection networks in the way we had intended. And our referral incentive positivity rate ends up being a lot lower than we expected. And I think we're starting to realize that the money is not the thing. And the money is like respectful reimbursement for, the person's time, but that we need some other way to like engage people outside. Is there anything that comes to mind? I'm still digesting a lot of what you said, but that maybe you've taken from this, like other ways to engage people in non-financial incentivization to engage their community, to get them in, to get them treated, anything that comes to mind?
Well, I guess, again, peer champions, and I mean, this was an outreach van, but it was still parked at particular locations, so people still had to go there. I believe Phil has a presentation tomorrow about very much like going out to where people are, rather than just, waiting for them to come to you. I think that's, what we really need to think about for, reaching, the really marginalised of the marginalised people. See, Margaret's gotten up to make a comment as well. She might be able to answer that question better than me if we have time. Phil, up to you.
We're pretty close, Margaret, so I'll give
I'll
you
be
10
really
seconds.
fast. Yeah. It's the nurses developing long-term relationships, and then the van being there for the by the way. So I don't want to have that treatment today, but I know that I trust these people and they'll be here tomorrow, and then I come by. So it was a combination of things, but it was being out there and trusting the nurses that you get the secondaries in.
Well, thank you, both of you. Thank you, Margaret, and thank you very much, Brendan, for a fantastic talk. I'm going to introduce the next speaker now. This is Professor Nicolas Nagot. Nicolas is a professor in clinical epidemiology at Montpellier University and a researcher in the pathogenesis and control of chronic and emerging infections. And he's been working in that field for over 20 years. So over to you, Nicolas.
Okay, thank you very much, Mr. Chairman. I'm very, very honored to present the results of the DRIVE-HC study on behalf of our large study group that I will acknowledge at the end of this presentation. So this study took place in northern Vietnam, so a bit of context for those who are not familiar with this country. Vietnam implemented a very strong program for people who inject drugs since about 2008 with pioneering methadone clinics and harm reduction implemented by community-based organizations supported by national NGOs, universal ARTs available for many years. And in terms of drug consumption, heroin is currently the only injected drug, and there is yet no access to DA in the country, although this is changing very rapidly. So the study was implemented in Hai Phong, which is a 2 million inhabitant city in northern Vietnam. This city pioneers intervention for PIWID. In previous study, we estimated that there was about 10,000 people who inject drugs in the city, with a HIV prevalence of roughly 25 to 30%. So in this setting, with colleagues from Hai Phong, Hanoi, and New York University, we implemented a large research program called DRIVE, which aimed at ending the HIV epidemic among people who inject drugs from this city. For this purpose, we implemented large repeated RDS surveys, which were accompanied by CBO support for linkage to HIV care for those HIV-infected participants and to methadone clinics. And also these CBOs implemented harm reduction activities. So this program was pretty successful. We reached more than 3,000 people. And during the study period, the HIV viremia decreased from 7% to 3%, with a very low HIV incidence, which basically defined the end of the epidemic in this population. And though the next question was, could this strategy, which really proved successful, could do the job for HCV elimination? So we designed an intervention trying to address three pillars of HCV elimination. First, to reach high intervention coverage, and really the RDS approach proved very efficient to reach the hardest to reach people. And I mean by this, those not engaging HIV care or OAT. And like for HIV, there was no HCV model of care, so we established an HCV model of care integrated within the local health system. We used CBOs to improve the referral to HCV care, which is a classical issue in the cascade of care. And these CBOs member insisted to be present during the HCV consultation to reduce the stigma in these health services. And finally, they also supported treatment adherence for the participants in need. And then we wanted to encompass the whole spectrum of activities for elimination up to the prevention of HCV reinfection, and the CBOs were involved in case management, harm reduction, counseling. So basically our objective was to assess the effectiveness of such a model of HCV screening and care. Again, encompassing the whole spectrum with an outcome at 48 weeks. And for this purpose, we used the outcome for one RDS surveys of the DRIVE program. And we wanted to estimate what we could achieve in terms of cascade of care using one single RDS. So we enrolled adult people who self-reported injecting drugs and who had a positive urine test with heroin, and we used this urine test for assessing other drug use as well. So basically the study design was this one. After the RDS survey, people positive for hepatitis C with a detectable HCV RNA were referred to one of the three hospitals where we implemented HCV clinics. The drug refill was organized at week 2, 4, 8, and 12. People were seen again for RSVR 12, and our primary outcome at 48 weeks. We use a standard fixed dose combination, and participants were compensated for their time and travel at the study visit. So during this RDS survey, we enrolled about 1,400 participants in less than 3 months. 72% of them had a positive HCV serology, and among them 84% had hepatitis C. So describing the participants with hepatitis C, 96% of them were men, and this really is the pattern of people who inject drugs in the city. There are very, very few women. They were 41 years old on average. 36% of them were on HIV with a very good cascade of HIV care. About half of them were not engaged in any addiction or HIV care, and 28% had severe fibrosis. So here is our result of our cascades of HCV screening and HCV care. In terms of screening, in blue, we achieve very high results where 95% of RDS participants received their final HCV test results, which included serology and, for those positive, HCV RNA. And then among the 875 participants identified with hepatitis C, 80% attended the HCV clinic, and then among them, 96% started HCV treatment. 92% of them were cured at RSVR 12, and 92% of them were still free of HCV at week 48. So in terms of outcome, about 80% of all participants identified at the RDS survey were initiated on treatment, and 2/3 of the same people identified at the RDS survey was free of HCV 1 year later. In terms of reinfection, probably thanks to the work of the CBO, we had a pretty low HCV incidence at 4 per 100 years between SVR12 and 1 year follow-up. So this strategy was pretty successful in low-middle income countries such as Vietnam. We have planned a modeling exercise which is currently done by the Peter Vickerman's team in Bristol to see whether by repeating RDS surveys we could achieve elimination in this 2 million inhabitant city, as we did for HIV. And also this modeling exercise will tell us whether this strategy is cost effective. There are limitations, of course, for the extrapolation of this data to other settings. It was a single site, single city. We didn't use, but the CBOs were pretty experienced for the different tasks they had to do. The OAT coverage was pretty high, about 40%, and the ART cascade of care is very high as well, which may not be the case in other settings, including in Southeast Asia. If we think of elimination, clearly this community-based strategy should be complemented with testing and treatment of HCV in care in HIV settings and methadone clinics, which is probably easier to do than testing and treating people from the community. Interestingly, this approach is also relevant in high-income country. We believe it is relevant. We tested it in our home country in Montpellier, in France, and I warmly encourage you to have a look at the outcome of this study, which is reported in poster 130, where it was also pretty successful in a different context, of course, but where we could really reach those who were not yet in care, engaged in care and not tested. And this approach is also relevant for other drug-related infection, HIV, but also TB, tuberculosis. So just to conclude, the key of success, I think you understood, were really the major involvement of the community-based organization with whom we have really developed a strong partnership at all stages of the study, and well before the beginning of the studies, when we spent hours, days discussing on the study procedures, and they were really involved in all steps. The RDS survey took place in their premises, in 2 of their premises in the city. They were involved in all desks of the survey. They were involved in linkage to care, and this was not. This was pretty demanding in retention to care, in treatment adherence, in collaboration with the healthcare staff in the HCV clinic, in the prevention of HCV reinfection through individual counseling and group counseling as well. And finally, all this in addition to their usual field work, both at home visits, meetings with family, and in hotspots. So I would like to really congratulate them and thank them for this great collaboration, and to acknowledge also all our colleagues from Vietnam, from New York University, and particularly Don Desjarlais, and from England, the Bristol team, and the teams in France from Paris and Montpellier. Thank you very much.
Thank you. Does anybody have a question for Nicholas? If you do, pop to the mic. And I'll also say we haven't had anything come through on the app yet, so if you're nervous to, you can put the bit anonymously if you like, and I won't read out your name. I have a very quick question, really. It's just about now. Obviously demonstrated that's effective in the setting that you did it. What will be the plan, if any, to sort of scale that a little bit further across the country? Is there support? Is there funding to do that?
We are working on it, clearly, because, we believe it was really successful. The key issue is the provision, the procurement of DAs. Everything was free of charge. So there are new opportunities. The National Health Insurance is envisaging to include DAs in their in the drugs they will reimburse, not probably 100%, but at least 80-90%. Complementary funding will come. The Global Fund is also changing its approach in terms of DA procurement in these countries. So there will probably be opportunity to go up to the end of the strategy and see whether we can really go to elimination.
Cool. Thanks. And just very quickly as well, I just noticed, I think it was about maybe 1 in 12 people had, unless I misinterpreted it, might have been reinfected within the 36 weeks between the SVR12 and the 48-week follow-up. There was about 50 or so people. Are there any sort of parallel efforts around sort of reinfection prevention, as the, OAT and NSP access and so forth, able to cope?
We had very few reinfections.
Oh, really?
It was, sorry, I can go back, but I can't remember the exact figure, but it was not much.
I was interpreting that difference between 629 and 580 as being people who were
It was only 16 people out of 600.
Oh, okay.
So in terms of person years, it's only 4%
Okay.
reinfection rate. So,
Okay.
so we believe it was, it's always too high, but it was reasonably low enough, probably.
Cool.
Very impressive data. Thank you very much, Nicholas.
Thank you.
So next up we have Dr. Matthew Lambert, who's a clinical instructor at the University of Wisconsin-Madison and also holds a role in public health at the Bureau of Communicable Disease. And he's going to speak to us about understanding attitudes and concerns regarding the use of molecular cluster detection as a hepatitis C elimination strategy, a qualitative study of persons who inject drugs.
Thank you. Thank you for that introduction, and thank you everyone for being here today. Let's see if I have this clicker. Yep. Good. So I'd like to preface my presentation with a statement acknowledging and thanking the people who inject drugs and people living with hepatitis C whose contributions to this project were invaluable and who generously shared their personal stories, experiences, and time with our team, and whose research this wouldn't be able to be done without. I have no disclosures of note or no interests of note. So initially, the project overview. This project sought to answer the questions: what attitudes towards the use of molecular surveillance strategies for the prevention and treatment of hepatitis C do people living with hepatitis C and people who inject drugs hold? And furthermore, what do they see as barriers or facilitators toward its potential practical implementation? So why ask this question? To date, molecular surveillance or virus cluster detection and response has seen utility in responding to the HIV epidemic. It currently stands as a keystone in the fourth pillar, the respond pillar, of the Ending the HIV Epidemic, or EHE, initiative in the United States, which was launched by the United States Department of Health and Human Services in 2019. Its use was initially actually met with significant concern from various involved parties, including stakeholders, at various different organizations, which prompted a series of national meetings with diverse representation from multiple states, local and tribal health departments, as well as people in the community, to review an ethical framework and best practices for its implementation in combating HIV. Some of the themes that emerged from these meetings included the need for iterative community engagement, evaluation and monitoring of the risks and benefits of molecular surveillance or epidemiology, competent communication and education to the public, and best practices on data sharing and security. So we actually sought to begin a similar conversation with stakeholders and people who inject drugs surrounding the potential use of molecular cluster detection in hepatitis C. Recent years have seen the development of the global hepatitis outbreak and surveillance technology, or GHOST technology, by a team at the CDC. And I'm going to use their words here. As described as a cloud-based system that's composed of a set of bioinformatic tools for controlling the quality of next-generation sequencing data and automatic extraction of information on transmission clusters. It integrates bioinformatics and information technology and enables all users, regardless of their computational expertise, to conduct independent, accurate, and reproducible hepatitis C virus molecular surveillance. This pictured here is a graphical representation of what the GHOST model can produce. The orange node in the center there is known from an epidemiologic standpoint from case investigations to be a source of an outbreak of hepatitis C, with the blue nodes being clustered and linked to it, and the green nodes, additional sequenced hepatitis C viruses that were not linked to that original cluster but were from the same time period. Excuse me. So it has been shown to provide some new insights into outbreaks, largely in retrospective use, for example, demonstrating large-scale ongoing transmission of hepatitis C as an underpinning of an HIV outbreak in Scott County and surrounding counties in Indiana, another Midwest state in the United States. And its future prospective application could lead to targeted control efforts in lower resource communities, potentially. So our study team consisted of individuals with varied backgrounds in clinical medicine, medical research, public health, healthcare law, and policy, and utilized this to create a interview guide and standardized description for molecular cluster detection in the context of a proposed application for hepatitis C control. Participants were recruited from among people who inject drugs, who recently tested positive in the past 3 years for hepatitis C at 2 syringe service program sites in Wisconsin, and interviews were conducted in 2 sequential rounds in a semi-structured fashion with multiple opportunities for patients to ask clarifying questions. Some of the themes that were noted to emerge in the first round of interviews informed changes to the interview guide and to the description of molecular cluster detection for the subsequent round. These are the demographics of the participants that were recruited. 10 participants were recruited for the first round of interviews, with 9 in the second round. 6 of them returned for the second round and 3 were new. The average age across both rounds was in the mid-30s, and most of the participants self-identified as white. So some of the results overall, actually the kind of broad themes that emerged from this were the concept of a model utilizing molecular cluster detection and contact tracing was largely positively received by participants, who also identified several barriers related to largely confidentiality, healthcare engagement, and how the educational or kind of descriptive material regarding molecular surveillance was presented. They also expressed a fairly high amount of trust in sort of the syringe service programs as communicators, and to a lesser degree, but still a significant amount of trust in public health departments. So the positive attitudes, and I'm going to go through here, and as I talk, the quotes kind of supporting what I'm talking about are going to be on this screen. I'll read through a few of them. But positive attitudes surrounding the potential use of molecular cluster detection were largely centered around perceived benefits to community health. Specifically, the participants expressed a sense of pride and agency if the data that they provided, either through their virus or through contact tracing, was used as an aid or in response to a theoretical outbreak or cluster of cases. Furthermore, participants indicated a similar sense of altruism when considering how data provided could be used to intervene or interrupt chains of transmission by identifying individuals who may have had a high-risk exposure to hepatitis C virus, and then subsequently linking them to treatment. And these quotes kind of demonstrate that there. Many also indicated that they would feel gratitude and a sense of inclusion if testing of their hepatitis C virus indicated that they were part of a cluster, and then a health department subsequently, or syringe service program, subsequently reached out to them specifically with the intent to linking them to care or treatment. However, there was also a sense of guilt in some participants that they may have potentially been linked to a cluster that could have exacerbated the spread of hepatitis C. Overall, this positive reception was somewhat tempered by a number of identified barriers. Chief among these concerns, and this was similar to some of the concerns, like I mentioned earlier, related to molecular cluster detection for HIV, were concerns regarding privacy and confidentiality of the information, both related to contact tracing and related to genetic data, which touched on multiple aspects of the scenarios discussed. During conversations in the first round of interviews, many participants expressed as an initial reluctance to participate in contact tracing as the act of giving up names or those that might have shared injection supplies with carried an overtly stated or a subtext of fear that sharing this information with health officials could lead to further stigmatization, social embarrassment, and or legal or criminal troubles. This was somewhat mitigated by reassurances of confidentiality and consideration of community impact, which were emphasized during the second round of interviews, but it still remained a significant concern. These concerns were further mirrored when participants were asked to imagine scenarios in which they were contacted by health officials to be notified that they had potentially been exposed to a cluster of hepatitis C virus transmission. Initial responses were characterized by suspicion and skepticism, but some of these turned more positive or neutral if testing and treatment were to be offered as the primary purpose of this contact. Privacy concerns continued when considering using viral genetic data to identify clusters. Many of these concerns were rooted in stigma. Specifically, participants raised concerns being identified as patient zero, or felt that any real or perceived implications of directionality of transmission during the process could be exacerbated and result in social ostracization or criminal and legal troubles. Emphasizing that this was not possible, nor a focus of the molecular cluster detection served as a somewhat mitigating factor, as did actually an analogous comparison to genetic sequencing of COVID-19 outbreaks. One more time. Sorry. Participants identified additional barriers in engaging with the healthcare system necessary to utilize the strategies. For most of these concerns were centered around consent, notification that additional genetic testing would be performed on their hepatitis C virus. Although sequencing can be routinely completed on, for example, COVID samples without special consent, opinions among participants were mixed. If they themselves would wish to have an option to opt out of additional genetic testing being performed on their virus. However, almost all of them did feel that others, or some people in general, would want to be notified about the additional genetic testing. Many felt this way, also thought that some may opt out of testing completely if genetic testing was to be done due to concerns about privacy, although they did not want to opt out themselves. Most of them identified educational materials and how they were presented as factors mitigating their own concerns regarding possible misuse of genetic testing of hepatitis C viruses. They also identified several terms and concepts as barriers to understanding and engagement, including the word surveillance, which carried a fairly negative connotation, which is why we chose cluster detection for the second round of interviews. And on that note, I wanted to highlight that the educational materials used in the first round of interviews left some participants fixated on personal genetics, with them somewhat kind of understanding that perhaps their own genetic material would be being sequenced and used rather than this genetics of the virus and the uses of using that for virus cluster detection. There was also repeated concerns surrounding directionality. So although refining the educational materials provided did help to mitigate these issues and was received positively by participants, during the second round, they did identify, like I mentioned, some problematic language. So since accurate assessment and understanding are the key to combating disinformation in healthcare and obtaining an accurate assessment of attitudes, our team partnered with Explainify, which is a company that specializes in creating kind of these explainer-style videos to create an educational video on molecular cluster detection, incorporating earlier feedback from the participants. And I don't know if I have time. This is 3 minutes long. I was going to show it, but I don't have time.
You don't have time, I'm afraid.
I won't show it today, but it is available on YouTube. I think it has about 3 views right now, so I can share the link later if anyone is interested. Apologies for running over there.
At the University of Wisconsin.
Oh, I'll just pass through that. So re-emphasizing some of the major points for the discussion, takeaways. And I'd like to acknowledge all of the other collaborators on this project and our funding from the Institute for Clinical and Translational Research in Wisconsin. That's my contact information. And again, feel free to reach out if you'd like the YouTube video link or the actual file itself. Thank you.
Thank you, Matthew. I'm sure we can get your YouTube hits up. Can anyone have any questions either on the microphones, or strongly encourage you to submit a question through the app just to reassure us that the app is working, because we haven't had a single question through on it yet. While we wait, I'll maybe ask, the kind of question about consent seems to have been debated. Do you yourself have a conclusion about whether there needs to be opt-out consent for this level of testing?
Right. No, it's a really good question. I think that, you know, the way that it's being done for other diseases, for example, for COVID, it's not a routine strategy to ask for consent. But if it was to be implemented, I think in an actual setting where that data was going to be utilized to contact subsequent individuals through a network, based on at least kind of the mixed data here, that I think that if we're going to listen to the folks who are being contacted through this, I think consent probably is at least an important process, or at least an opt-out consideration when we're doing this. Yeah.
Thank you. If we have no further questions then, thank you very much.
Thank you.
Great. Thank you, everybody. We're now going to change speed a little bit, and I would like to invite Evan Cunningham to the stage. Dr. Cunningham is a research fellow at UNSW Sydney, and his research is focused on addressing the remaining gaps in hepatitis C care through the use of effective interventions. Over to you, Evan.
Thanks for that, Phil. So we don't have lots of time, so we'll go through these quite quickly. Nothing to disclose. So very briefly, we know that hepatitis C testing and treatment remains too low in many settings to really achieve hepatitis C elimination goals. We did a prior systematic review that and meta-analysis that looked at all populations, but people who inject drugs really experience specific and unique barriers to care, and so they may need unique interventions to address these barriers. And so the aim of our study was to evaluate the impact of interventions to improve hepatitis C antibody testing, RNA testing, linkage to hepatitis C care, and hepatitis C DAA treatment initiation among people with recent injecting drug use. So I won't go through this in a lot of detail, but very standard systematic review methodology. We searched the key databases. The thing I want to point out is that we only included studies if they had a comparator. So if you don't see a study that you think should have been in here, that might have been why. And this analysis is restricted, as I said, to only studies of people who inject drugs. We categorized interventions according to what we thought was the primary intervention implemented in that study, and then we pooled the effect of those interventions using meta-analysis. So I won't make you read all that, but just to point out, we started with around 16,000 abstracts or records and ended up with about 45 that looked at improving care for people who inject drugs. And that included 21 for hepatitis C antibody testing, 5 for RNA testing, 17 for linkage to care, and 20 for DAA treatment initiation. So there are sort of 3 categories of interventions that we found in this process. The first is interventions addressing patient-level barriers to care. So first was patient education, which we found to be effective at improving antibody testing in 5 studies. So that circle in the top corner of those boxes represents the number of studies contributing to that pooled effect. And patient navigation was effective at improving linkage to care in 3 studies. And I have single studies down at the bottom. I won't be able to go through all of them today. And then there were the interventions which were effective at addressing provider-level barriers to care, and the one that we found here was provider care coordination. And that was effective at improving antibody testing in 2 studies and a single study each for RNA testing and linkage to care. And the last category of interventions that we found was those addressing system-level barriers, so those that simplified hepatitis C care. And so the first one was point-of-care antibody testing. Well, the three are point-of-care antibody testing, dried blood spot testing, and integrated care. Were effective across different stages of the care cascade, and integrated care was quite effective across the cascade, although we still do have small numbers of studies there, so 2 and 1 study for the different outcomes. So this is just sort of a summary slide of everything. I thought people might want to take a picture because it sort of pulls everything together and things I can't say. But I just wanted to point out that although we have quite a few different interventions that have been assessed, we are lacking some repeat data. So we only have single studies for all of the ones that I've turned gray here. And so there is still some work to do to really work out what the effect of these interventions is, and particularly as people who inject drugs aren't a homogeneous population, they might not be as effective depending on the setting and barriers in that setting. So I think what's important is that models of care be designed with the setting and population in mind. Like I said, it's not a homogeneous people who inject drugs population globally, and so it really needs to address the existing gaps in care and the unique barriers faced by that population. I haven't been able to go into it, but multiple interventions, studies which use multiple interventions were quite effective across the cascade. And so that might be a strategy by addressing multiple barriers to care. But we do need some further work, including randomized trials, to really confirm some of these results. And just like to thank my co-authors and everyone who provided data to this work. And if anyone's interested in the primary analysis, which includes all populations, that's been published and the link is there. Happy to take questions.
Great. Thank you very much, Evan. Does anybody have a question for Evan? Seems not. I do have a quick question. That obviously the integrated care effects size seems very large.
Yes.
What could you just, only a couple of studies, can you tease out what was that comparator? I mean, how disintegrated was the care that they were comparing it to?
Yeah, so those ones generally were quite disintegrated. So that might have been like a emergency department where they weren't really thinking about hepatitis C at all, and then they integrated testing into so that went from nothing to something. So obviously a really large effect size sort of thing.
Okay, yeah. Okay, well, I think we're out of time. So Evan, Perfect. Thanks for your work. Great.
Thank you.
Thanks.
And I believe we're going to go online now to Tim Brodie, who is a Senior Research Fellow at the Centre for Social Research and Health, University of New South Wales, Sydney. Can we go there? Tim, can you hear us?
Yes, I can. Can you hear me?
We can hear you loud and clear. You have the floor. Take it away.
Fantastic. Thank you. Wonderful to be joining you from the middle of the night here in Sydney for a quick whirlwind presentation. So today I'm just going to be talking briefly about some analysis we've done looking at factors associated with stigma, discrimination and negative healthcare treatment among people who inject drugs as part of the Ethos Engage study. So I want to acknowledge from the outset the rest of the entire study group involved in this project, many people involved to make this project happen. Just as a quick bit of background, stigma, as I'm sure everyone is quite well aware, has a lot of negative consequences on health outcomes, things around reducing healthcare access, risk behaviour, mental health and well-being. So in this analysis, we looked to evaluate factors that were associated with experiencing stigma in relation to injecting drug use or hepatitis C, and also being treated negatively by health workers. So the analysis looks at some data from Ethos Engage, an observational cohort study of people who inject drugs in Australia, and looking at a couple of key outcome measures around stigma. The items are listed there on the screen. In the past 12 months, so looking quite recently, whether people had experienced stigma or discrimination in relation to injecting drug use or hepatitis C, and to the extent to which they felt they'd been treated negatively or differently by healthcare workers. So we looked at just over 1,200 participants, average age of around 45 years. About 2/3 of the sample were male. You can see there the experiences of receiving OAT, 72%, 64% reported injecting within the last month, and 65% of the sample had been diagnosed with hepatitis C. Over half reported any stigma related to injecting drug use. just over a third of people who had been diagnosed with hepatitis C reported that they'd experienced stigma related to that hep C, and 45% of the whole sample reported negative treatment by health workers in the past year. So condensing a whole lot of analyses into one slide, these are the results we found for the factors independently associated with each of those experiences of stigma. So there's quite a lot to go through. And so just briefly, I wanted to touch on a couple of things, noting that being female was associated with increased odds of experiencing stigma across all three of these in terms of injecting drug use stigma, hep C, and treatment from healthcare workers, as was receptive needle or syringe sharing. Couple of the others where we can see a bit of similarity between a couple of the stigma measures, so past year hospitalisation and arrest, and also homelessness coming out in a couple of them. But then we've also got some that are unique to one particular form of stigma. So in particular, looking at stigma related to injecting drug use, and you can see that OAT history, both previous and current, is associated with increased odds of stigma and also overdose, whether in the past year or longer than 1 year ago. So quite a couple of similarities there, obviously, and also some individual differences to kind of tease out the differences and really highlight some of the complexity around the type of stigma and discrimination that participants within this study had reported they'd experienced. So basically, to wrap all of this up into a really quick presentation, in looking at the factors that were independently associated with stigma, we found that there were those similarities across some of the measures. So particularly looking at gender and receptive needle and syringe sharing came through as very strong predictors or strong associations with stigma. But then we also noticed those contextual differences, particularly around drug treatment and also overdose. And then regarding hepatitis C, recent hepatitis C testing coming through as having a significant effect. So what we're working through now is looking at the implications of this, and essentially in any effort to attempt to address stigma within healthcare and developing interventions, really what we're looking at is highlighting these factors that play into those contexts and how that may differ for the different groups within a broad population of people who inject drugs. So I know this is a very short presentation, but also happy to take any questions now if there are any from the floor. Thank you.
Thank you very much. Tim. Do we have any questions on the microphones or on the app? Yeah, please do.
Hi, thank you very much. That was a very interesting presentation. My question to you is, do you get any idea why women get this increased stigmatization across all the different groups? Do you have a feel for why?
Short answer is no, not necessarily. One of the things that we've talked through at a team level, the team that I work in around stigma on a regular basis is basically around social perceptions of, what's expected or, what's appropriate for certain people. And so I think some of the more broader societal perceptions of what's acceptable for women as opposed to what might be acceptable for men kind of comes into it there. So some of our colleagues at the Kirby Institute, I know, have done some more in-depth work, particularly around people who, looking at the aspects of gender around hepatitis C testing amongst people who inject drugs. And it's, around those cultural norms has come through in some of the qualitative work, but it's certainly an area that we're keen to try and unpack a little bit more as well and see, exactly what's playing into that. That's kind of just a working theory at this point.
Thank you very much, Tim. In the interest of time, we're going to have to move on. So thank you for getting up in the middle of the night and sharing your work with us.
Great. Thank you.
Thank you very much. Our next speaker, great pleasure to introduce Annie Madden. Dr. Annie Madden is currently a part-time project lead at INPUD, a part-time executive director of Harm Reduction Australia, and has recently completed a PhD on drug user representation in high-level policy settings at UNSW. And Annie has an incredible track record of representing people who use drugs over many decades in Australia and globally. Over to you, Annie.
Thank you very much, Phil. Hi everyone. I'm going to be just briefly talking about the role and importance of community-led values and preferences research for developing models of care and other interventions with people who use and people who inject drugs. I'm going to talk about, use an example, some values and preferences, community-led values and preferences work that I was involved in on behalf of INPUD and with colleagues from the Key Population Global Networks in relation to the recently released WHO key populations guidelines on HIV, viral hepatitis and STIs. And as you can see there's 4 key population global networks there that were involved in the research. INPUD, International Network of People Who Use Drugs. GATE is the Global Trans Organisation. MPACT on behalf of MSM Gay Men, and NSWP, the Global Network of Sex Worker Projects. And we all were involved in doing WHO commissioned us all to do our own values and preferences research with our communities, and then we brought that together. So I'm going to take you through just what we did, and then rather than I'm not going to talk to the findings of the research, but more finish up with some comments about why this type of research is so important in terms of developing models of care and what you can get from that, and some final comments on what is community-led research and what isn't. Yes. So in terms of the rationale and objectives for the values and preferences research that WHO commissioned, from WHO's perspective, they were looking to ensure that the recommendations that they were making were informed by the values and preferences and the lived experiences of the intended beneficiaries of the guidelines. This type of research we did it largely because it can provide very rich insights into what was valued and preferred and why key populations held certain values and preferences. And we didn't just look at sort of the priorities, the health priorities that the key populations might have, but we also were able with this research to look at some of the sort of structural barriers and look at that in the context of people's values and preferences, and also to look at enablers, what might address some of those barriers as well. So it gives a very holistic picture. It's obviously qualitative research. This was also really significant research because it is the first time that community-led values and preferences qualitative research has been included in the WHO guidelines development process, in addition to the clinical evidence that would normally or typically drive that kind of process. So there's typically just the clinical evidence that drives the guidelines and the recommendations. And so this was really significant that this new research was built in. In terms of our methodology, each of the global key population networks selected participants who were over 18, had to be able to speak English, French, Spanish or Russian, and were a member of one of the key populations concerned. In terms of recruitment, we interviewed 229 participants across 69 countries from all 6 WHO regions, and most of those countries were low or middle income countries. Every network collected its own data, as I referred to. Each network had 2 primary investigators, and then we employed peer or community-led regional community consultants to undertake focus groups. We did 32 focus group discussions and 61 semi-structured interviews. Once the data was collected, we thematically coded that data using a shared coding framework that we developed collectively with the key population networks from the different communities, so that the point being we developed that framework before we collected the data so that we could identify commonalities and also identify outliers across the communities as well as within them. Why was this research so important? Well, it was a chance to influence and inform the WHO technical guidance on what works and why it works. in terms of what key populations want to see in terms of HIV, viral hepatitis and STI services and interventions. It identified a preference for community-led and peer-based models of service delivery that would not have been identified using the clinical evidence or the RCTs alone. And it highlighted that efficacy of models of care are reduced by structural barriers and drivers of vulnerability, in particular criminalisation, stigma and discrimination, again, which would not have been identified through just looking at the clinical evidence alone. Finally, I just want to finish by just talking a little bit broadly about what is community-led research. I've used that term throughout and what it is not. So to start with, what it is not is it's not about just checking in with or asking service users about what they think about a model of care, or even coming to communities after a project is already designed and funded and has ethics and just seeking community endorsement or box-checking exercises for ethics. Community-led research is where you have, in this case, people who use drugs and their organisations engaged in every aspect of the research process, from concept, funding, design, protocol development, ethics, data collection, analysis, right through to dissemination. And it takes many forms, there's lots of different methodologies, but I think we need to understand that community-led research is real, proper, legit research and needs to be recognised as such. And research like values and preferences is really, really useful to do ahead of developing models of care and interventions, because it can just show you things that you might not otherwise have understood about the populations you're working with. Thanks.
Thank you. Thank you very much, Annie. Incredibly huge and important piece of work, condensed very well into 5 minutes. Before we I just wanted to check, I haven't spotted a potential final speaker, Regina Matufi. Is that person in the room? No. Okay, so in which case, if anyone does have any questions for Annie, or to elaborate on something, I'm sure, Annie, you wouldn't mind. Does anyone have anything they'd like to ask before the lunch break?
Coffee break.
Coffee break, yes. I'm a bit I've always been a few hours behind.
Difficult time zone.
Yeah. Okay, well, Annie, thank you so much for that wonderful work. So that concludes our session today. Thank you all for attending, and go and enjoy the coffee.
Thank you.